of the large attendance we have here today. I think we pretty much have every state covered and many of the subregions across the country. So welcome, and let's. I think we're looking forward to a great two-way interchange here. So just moving into the agenda itself, we plan to cover a lot today, and we'll hope to finish up with a mock negotiation session. So I'm going to begin with talking to you about health reform and some of the key changes that are expected, and more importantly, any of the changes that have occurred even in the recent months. We did a session the beginning of the year, and there have been some changes even since that time period. Secondly, Matt's going to be talking to us a little bit about the dynamics in this EMS system, and what the potential impact is and strategies to have an impact on the impact. Bill Bullard is going to be talking about benchmark communities and many of the innovations that you hear bannered around, but he'll be talking about communities that are actually in the business working on these innovations. And then finally, Bill and Matt and I will be doing a mock negotiation session, an EMS provider versus a payer or a hospital provider, the actual buyer of service, whoever that might happen to be. That label and that title can change, but we're going to walk you through what might look like a successful or perhaps not even a successful venture, because our mock negotiation session is not staged. We have a script, but there's no guarantee what the outcome is going to be, depending on what questions are asked and what answers are available. And then periodically throughout the session, about midway, I'm going to ask Juliana to let us know of any questions that you have, and then at the end, questions. So don't forget to type in your questions under the question box below, and once you've sent those, we will no longer see them. They'll be sent, and Juliana will screen those and help us identify when questions are available. So you're ready to get on this puppy and take a ride down this this environment that we're calling health reform today? Well, let's just talk about a couple pieces of this health reform, and maybe some of the drivers that were instrumental in getting us to where we are today. And it's not really a very pretty picture. The United States spends on average per capita more than any other industrial nation in the country, and we're far above the next closest nation, which is Switzerland, and Canada's down below that. And while many of these other systems speak to nationalized health reform, they predominantly rely on, many of these systems, on a private healthcare delivery system that in many cases is funded publicly. Now there's some exceptions, such as the United Kingdom and things of this nature, but even if you go to Canada, you'll find that it's really a private system driving the delivery of services funded by a public appetite to fund those kind of things. We have one of the lowest expectations for life in the world. We spend the most money, and we have one of the lowest expectations for years lived. I'm fortunate because some data just came out that I live in the Bay Area of San Francisco, California, and it turns out we have the highest expectation of life lived in the United States, which isn't saying such a great thing. It's about 82 for female and about 80 for males. But when you take that and compare that in Kentucky, where the age difference for an average male is around 70 years old, and then for females around 74, you can see logarithmic differences depending on what part of the nation you're from, and thus you know, really setting the background and the stage for why some sort of reform is needed. If you look at where the spending occurs, they occur, it varies widely. There's a lot of clustering in the South, the Midwest, and by and large, you can use as a rough guide that where healthcare delivery is in abundance, and where health plans are, if we say, least leverage, that is the least amount of managed care, more like the commercial plans, and I say that with some respect. There aren't that many commercial plans anymore, the so-called Blue Cross positives. But if you look at communities that are highly managed, by and large, you'll see lower expenditures, California being an example of that. Now, we also know the quality varies significantly, and if you were to juxtaposition this slide over the last slide, you'd see no relationship at all as to where the highest expenditures occur versus the highest quality of care. In many cases, there'd be complete contrast. So when we have the highest costs, when your higher costs don't drive higher quality, and then we have tremendous variability in quality in general, then we've got a recipe for a disaster. It was spiraling out of control, and by any person's estimates, including health economists, no end in sight. So the other piece that's been such a huge challenge in our nation is the number of uninsured, approaching basically 50 million people back in 2010. This slide only goes to 2009, but it dropped just slightly in 2010, and it's grown dramatically from, say, 1987, from 30 million all the way to 50 plus million, about an uninsured rate of 16–17%. It varies by state. Texas and California having the highest uninsured, and many people think that that's largely because of the undocumented aliens, but it's not true. If you look at the profile of the uninsured, only about a third are undocumented residents in our nation. They're mostly younger people, many of which are employed, and many of these people choose to live without insurance, even though they have the ability to afford insurance. They have other priorities, financial expenditures that they, or excuse me, expenditures that they'd like to have in life over and above paying a health care insurance policy. So a rising uninsured, complexities in cost, complexities in quality, thus again a perfect storm, if you will, for purposes of looking for reform. Now, what are the Affordable Care Act? Let me set this up just a little bit. We are witnessing today the most significant change in healthcare public policy that's occurred in the last 50 years. Let me just let that sink in just a little bit here. This even surpasses Medicare and Medicaid from the 60s. And I want to point out to you that many large entities opposed Medicare back in the 60s, absolutely opposed it. And if you go back to the early turn of the century, most providers opposed insurance. And you say, well, what's going on? It was perceived to be a lot of government intervention. Now, today, I don't think anybody would argue with insurance. And 50 years ago, people would say, well, Medicare and Medicaid, particularly Medicare, was a bad thing. But remember, a lot of people over 65 weren't working. And by and large, the way you got insurance in the old days, by and large, it was exclusively through work. So the older population was uninsured. It's very interesting. Now, so those were unpopular programs, but we've gone to love them. I mean, I don't think anybody makes a huge living off of Medicare, but we certainly do reasonably well. Medicaid is a different story. But when you think about the pharmaceutical benefits back 3 or 4 years ago that were established, Part D coverage under Medicare, there was a lot of opposition to that in this country, and a lot of perception there was more government control. And today, I don't think there's a Republican or a Democrat on either side of the House that would allow you to wrench that benefit away. In fact, under health reform, we're going to close the so-called donut hole in pharmaceutical and shore that up even better. So what happens under Affordable Care Act, the Affordable Care Act, or what we call health reform? We're going to have coverage expansion. This is the #1 step towards getting more Americans covered. It should cover about 30 million more people than we are today. There'll still be a gap, but 30 more million people will have insurance. And depending on what state you live in, there's a very helpful map that you can go to on KaiserFamilyFoundation.org. and that's kaiserfamilyfoundation.org. That's not a health plan site. That's a neutral third-party entity set up by the Kaiser Family Foundation to provide independent, objective advice on public policy and healthcare in this country. And they show by state which states will have what kind of conversion factor from uninsured to insured. So in California, it's 47% of the uninsured will convert. There's some states as little as 0%, and that's Massachusetts. You say, well, why Massachusetts? Well, they just underwent their own health reform 6 years ago, and by and large, with very, very small exception, most people are insured in that state today that they weren't before. We're also going to have insurance reform. There's a lot of things that are happening that have already begun to happen. Most people think of, next year as being the big set-off point, but actually a lot has happened already. Young people have gotten insured, typically under their parents' policy, and that's insured somewhere between 2 to 10 million people across the country, depending on whose numbers you use, that otherwise would not have had insurance. So one thing I noticed is we got a rebate from our insurance company just the other day, and because now insurance companies are required under health reform to limit their losses, what they call the medical losses. They have to spend so much of their dollar, 80% of the dollar minimum, towards health care benefits, thus leaving the 20% for profit and overhead down to a minimum. And you say, well, 20% is pretty high. It is pretty high, but still we have insurance companies issuing rebates now based on exceeding that limit. Before health reform, there was no limits. An insurance company could have a 50% pay loss ratio, that is 50% going towards health benefits and the other 50% in theory going to the pocketbooks of the shareholders and executives of the insurance company. That's no longer true. All insurance plans will have a provision that says it can be no more than 20%. So we're starting to see rebates, checks, payment reform and experimentation that's been going on, including 3 very robust opportunities going on in EMS right now, and an expansion of those planned with applications now pending for CMS in other areas for EMS and emergency departments. Prevention and community health, a number of these have already started. Prevention programs including benefits now that you can't be charged for, and things like colon cancer screening, annualized public health and public awareness education to your primary care physician. They get paid, but they just can't charge you for that service. And then primary care capacity and the infrastructure, particularly in relates to these community clinics. It's about $60 billion being invested in community clinics. The so-called, what we used to think of as free clinics, are being invested. So there's a lot going on in our industry right now. Again, the single largest set of changes, barring none, in the last 50 years. So it's a little hard to say exactly how many people will be insured, and you have to look at uninsured as sort of a national debate. Who's uninsured? So do you take somebody who's uninsured for a part of the year? Are they uninsured? If you have somebody that's uninsured for the entire year, is that your uninsured number? Generally speaking, no matter what numbers you get, it's between 12 and 16% of the population, edging closer to 16.7% in the last census, 2010. But then there's the underinsured, and one think of those as being Medicaid and below, and S-CHIP and family health care, which is another 10 to 25% depending on what state you're in. But even with the Affordable Care Act, there are going to be other issues. Physician cuts are a concern, especially payment cuts to physicians, although primary care physicians beginning next year should see a fairly robust increase in how they get paid. That's the design under health reform, to pay primary care better, but that's going to come at a loss for other specialists. So again, more money for the primary care physicians to incentivize them to get into that industry, and less money for some of the specialists. Out-of-pocket expenditures are expected to increase, although some of the early premiums being quoted in states, for example, like New York and California, show a 20 to 25% reduction in premiums for those that would participate through these health exchanges. So that's been a bit of a surprise. And so in New York alone, it's about a 37% reduction in premiums. So the numbers are still out as to what, if any, median out-of-cost expenses are going to rise. We do know that some people will choose a cheaper plan that has a higher deductible. And, of course, the big question always is, are these people insured? So there are no changes planned for Medicare, and that's really important because a lot of people think of, gee, health exchange, increase in Medicaid, but for a lot of the public, 80+% of the public, there'll be no changes at all. It's really the underinsured and particularly the uninsured that are going to benefit. Those that are going to move towards Medicaid, who otherwise hadn't historically qualified. That's all going to be paid by the federal government for the first 4 years, those changes. And then payment in general for services that for those that got no payment in the past. So some will move to Medicare and some will move to what we call a health exchange. And by and large, these are you think of these in the form of real insurance, Blue Cross type insurance, maybe with a higher deductible. But there are certain minimum benefits that are required under health reform, one of which, of course, is emergency services. And you say, well, that's a no-brainer. But, in fact, that wasn't a required provision. It had to be asked for. But the other two that are unique and new are OBGYN services, particularly labor and delivery, which are not guaranteed. Only 60% of all policies in the country cover this. And then mental health services will be required under all health plans beginning January 2014. So for some of us, that we think that may be a plus for especially our EMS crews and our emergency departments that are overwhelmed with mental health patients but nowhere to go. Now there will be a financial benefit for getting in that business. Now the other big question that's come up recently is this whole notion of Medicaid expansion. Which states are in and which states are out? As you remember, last year, a little earlier than this last year, the Supreme Court weighed in and took note that the Health Reform Act was really an endorsable act, and they memorialized those as being law. And I say those being the regulations and the statute themselves. But the one thing they said is you cannot force states to adopt Medicaid expansion. Now remember, the Medicaid expansion is all going to be paid for by the government for the first 3 or 4 years, but there's been some states, a large number of states, that have basically said, wait a minute, we're not paying for that after that fact, and if we're not going to pay for it after the fact, it's an unfunded mandate. We're just not going to pay for it. So these are the states in blue here that have said they're not going to expand. There are some states in gray that are still undergoing debate, and then there are those that have acknowledged right up front they're going to add expansion capability. That's a big deal. There's literally $100 billion in the line here. And so for those states that decide not to participate, that will be a loss of benefits for those states. Now, I think most health policies experts believe over time, may not happen year one, most of these states will migrate over and get the coverage, the Medicaid expansion coverage. And why? Because it's a huge benefit, more people will be insured, and by and large, in terms of public expenditures, getting care earlier in a more precise PCP, primary care physician way, is a way to go, and that's what keeps people out of emergency departments, and that keeps patients from using ambulance services. So we think that's important. Now, community health centers. I mentioned these so-called free clinics, $11 billion over 5 years to fund and expand these clinics. So there's one group of people that love Medicaid, and that's these community health centers. By and large, they get made whole. They get paid better than a hospital emergency department, a lot better. And so it's always interesting to hear a community health center saying, oh, we love these patients, and emergency departments saying, oh, these patients are definitely not positioned. And you know, honestly, there's some strong rationale for that. One of the rationale pieces of that is that at least with the community health center, they get a medical home. They can revisit. They can have all of their treatment needs taken care of by and large. Where if you go to the emergency department, you get episodic care. If you call EMS, that's all you get is episodic care for that episode. You don't get the referral to a specialist. You don't get ongoing therapy, mental health, or whatever got you to the emergency department in the first place or got you to EMS, the community health centers. And so many of these, if you will, systems that are around the country looking at benefits of health reform and the health center benefits are really looking at a medical home type of a benefit that will help our patients move towards lower cost settings. And in fact, some of these EMS innovations are looking at maybe transporting patients to a health center that can be set up and be verified and not to an emergency department. So a paramedic transporting, that's a possibility under this act. And so a variety of issues here are raised as well. I mentioned the wellness. So where are we going from here? And I got to tell you, I started in EMS a long time ago, but not when we were these rescue wagons, I think we used to call them. We call them inhalator units, if some of you are old enough than me. But we are moving in a direction, and it's I think we have a long way to go, but I think the direction is positive. And Matt will speak more of that, and then Bill will talk about examples. But I just want to comment that when you think of the expenditure, the payer for a premium dollar, just if you could just in your own mind take a look at a premium and what's spent. Let's say you spend $500 a month on a premium. If you just took 1% of that premium, or let's just say for purposes of evening out $100 per month, that's way understated per month, and you took that $1 and said, well, how much of that dollar, and it could be $500 or $1,000, what percentage of that and how is it spent? You can see here we've got the cost of administration, which is 10 cents, and we're saying the law says you can't spend any more than 20% on that now. And as I mentioned earlier in the talk, some of us are getting rebates when it's exceeded 20%. This happens to be Blue Cross. It could be any insurance. 33 cents goes to hospitals. 30 cents goes to physicians. 13% goes to drugs, dental services, so on and so forth. But if you think about emergency departments and then EMS, emergency departments represent about 1 cent out of a dollar, about 1% of the expenditures. There are some studies that suggest it's as high as 2%. But EMS represents a smaller segment of that, roughly 0.1% of that 1 cent. So 1/10 of 1 cent. And you say, well, that's not very much, and that's one of the reasons why we've flown under the horizon, under the radar screen, and most payers don't come at us and say, well, you're going to have to change the way you do business, or haven't historically, but we think they're going to in the future. If you think about that, though, we drive a lot of the expenditures for health care. Our patients get a lot of resources with minimal queues, right? You call for an ambulance, you're going to get a fire engine in most communities, plus the ambulance, and God help you, you might even get a supervisor, and who knows, if you're on the freeway or expressway, whatever you want to call them in your part of the country, you might even get an engine going one direction and an engine going the other direction, and maybe a heavy rescue, and oh my gosh, you now have anywhere from 3 to 5 pieces of equipment for maybe not a very strong case to be made after the fact, reason for having all that there. That patient is going to be transported to an emergency room, right? That's the model, right? We don't get paid unless we send our patients to the emergency department. And more importantly, if you decide you don't want to go to the emergency department, you're going to have to sign, about 10 pages of AMA, right, against medical advice waivers that says you could die if you don't go for that cut finger. So I'm being a bit facetious here, but that's the bottom line in our country. And then if you go to the emergency department, guess what? They're going to treat you like an emergency department patient that came by ambulance. And you're going to be, in many cases, moved to the front of the line, not always. Our emergency department system is under extraordinary distress across the country. And you might have tests ordered on you that you might not have had ordered had you not gone to the emergency department. You can see where this line of thinking goes. And then, oh my gosh, down the line, something might come back a little bizarre and you might get admitted overnight or to observation status. And this is the kind of stuff that drives payers crazy. You say, well, you represent 0.1 of 1 cent of the expenditures, but look what the risk is to us as a payer. It could be as high as 60% of the cost for those patients by those upfront, really minimal cues that drive maximum response. Here's what we know. We do not believe that because people are insured under health reform that they're going to start calling 911 faster and more frequently. We do not believe that's the case. We've seen no evidence to that fact, and in fact we have looked for publications out of Massachusetts, which is really the petri dish of a background on this subject matter, and there's been nothing published to suggest a blip on the screen of EMS responses. We just don't think that's a reasonable expectation of the public to suddenly say, I've got insurance now, I'm going to start calling the ambulance. That doesn't mean they're not going to use healthcare services to a greater degree. We just don't think it's going to come through the portal of an ambulance. B, we think emergency department visits are going to grow, again, organically. And the truth is still out in Massachusetts. There are a number of conflicting studies that show a modest growth, a minor growth, and a modest reduction in ED visits. And the latest paper shows a modest reduction of about 5% sustained. And that's against a backdrop of 5% gains across the country. So that's a big delta. That's about a 10% delta. Now, what do we know about that? We don't know a lot. They're still doing studies. And what we think is happening, at least the scientists that are doing those kind of studies are thinking that these patients are now getting services in an alternative way, and the system's working. They're getting lower cost services and lower cost settings that is mitigating the need to go to the emergency department for when things get really bad. And I don't know about in your neighborhood, but the Kaiser Foundation has published a number of studies over time that show the growth in emergency department visits in our country, and you can kind of do the surrogate of EMS here, is by and large not by the uninsured. It's by the insured that are using the emergency department at a greater degree. And these are patients that wait longer to get care, and when they do wait, they get sicker and they have more needs. And if we catch them ahead of that power curve, we, in theory, can provide a lower cost setting and mitigate their problems and de-escalate them, if you will, earlier. With respect to trauma centers, I know that's not our audience here today. We don't think that's going to change one iota, the number of patients that go to trauma centers. So organic. We don't see a big impact on emergency care resources by and large. I know this sort of flies in the wave of others that have a lot of anecdotal stories, but in terms of what the literature is telling us right now, either through the absence of literature or through actual fairly substantial literature, particularly on the emergency department side, we just don't see the big thrust to use. So what's likely to happen is people are going to be more insured. It could be as high as 39 million by the end of 2019. We expect 20 million in the first year or two. By the way, we start signing up people in most of our states. We start signing up in less than 6 weeks, basically about 6 weeks, October 1st. So it's happening. It's no longer 2 years out, 3 years out, 1 month out. It's 6 weeks out now, folks. And we're going to start to, qualify these people beginning in January. And I can tell you alone in California, we're spending $60 million just to get the website up and operating relative to insuring these new people. So that's a big deal. We do know across the country that about 43% of the newly insured will be Medicaid, and about 57% will be of this exchange category, which, again, I would caution you, but I think it's acceptable to use the term insurance, regular insurance. It's not a Medicaid product. It's not going to be a low-pay product. And that number will change. Those percentage will change depending on your demographic community, the percentage in poverty. It just depends on whether you qualify or not for these other plans. But by and large, a larger portion will not be Medicaid. The larger portion will be these exchanges. Now, how are we going to pay for all this? Well, it's an expectation that about a 716, and that should say billion, not million, $716 billion will come from Medicare cuts. And you say, whoa, that's a lot of cuts. Well, we do know there's a lot of opportunity here. And this is the Institute of Health Medicine's publication back in September of last year that just looked at healthcare expenditures in terms of excessive administrative costs, fraud, unnecessary services, and waste in general, and they found $750 billion in cost savings just using 2009 numbers. So one might say that that number is there, that it's available if we just look more carefully at how we do business and how we spend our dollars. And we do know that waste is rampant, and one cannot say, as I've heard an EMS futurist talk recently about the vast culture of waste and overuse in the EMS industry. Think about that, folks. The vast culture of waste and overuse, something we're admitting to ourselves privately, is contributing to this high cost. You know, are we in fact going to be able to produce the outcome confidence that we should be able to produce under health reform that says we are providing something of value? You know, even the entire framework of EMS gets shaken up a little bit. You know, we think about, you know, what our original cardiac arrest model was and the response times to that model and how we've allowed those response times to erode over time and lose that, you know, 6 to 8 minute standard that we originally were endorsing as part of the cardiac arrest model. Again, a model that suggested on a very small number of patients we could have a benefit if we got the ambulance, or in this case, more frequently today, the first responder, the ALS first responder with AED and citizen CPR. But absent that, a lot of what we do is not very well documented. And that's a challenge. There isn't anybody in this audience today that could look at each other with a straight face and say, oh gosh, you know, I remember that nursing home call when Dr. So-and-so went out of town, the medical director, and oh my God, we started getting all these fecal impactions and all these cases that otherwise would have been managed inside the nursing home but for that physician being on vacation. And fire and private crews telling me when we do our ride-alongs as part of our projects, our consulting projects, you know, this shouldn't happen. This is a waste of resources. So think about waste. And what is that waste and how could that be quantified? And is there opportunity in the EMS industry? You know, are we sending everything to everywhere regardless of needs or outcome? And I would think by and large the pendulum's definitely still swinging to the yes side of that equation. We've talked about emergency department waste as well, but we won't concentrate on that for this talk. And then of course trauma centers. You know, we're going to be moving, and I think the experts have acknowledged this now, from a fee-based, transaction-based service line where we get paid based on services rendered. It's a sick-based system, right? It's not a well system. It's not health reform. It's unhealthy reform. To a value-based system. So what does that mean? When we think about value, think about cost over outcome. What is the value of the services we're rendering, and what kind of outcome are we delivering? Is it worth the value? We do know that we could put a paramedic with an AED on every street corner. It is physically possible to do that, but at what expense? We would save a number of more witness cardiac arrests. We certainly would do that, but at what expense? You couldn't. It's like putting a cop on every street corner. Murder rates would decline dramatically. But can you afford to do that? No. We have to look for the bigger bang for the buck opportunities. Now, you should know that Medicare started many years ago looking at quality programs and outcomes. And they started to brace the hospitals and the physician providers to begin looking at these things. And now, beginning next year, the rate of penalty for not reporting on certain quality outcomes actually jumps from 2% to 3%. And so one might say, well, 3%, that's not much. By the way, you get a 2 to 3% gain if you meet all the requirements as well and meet certain thresholds. So there's a quid pro quo there. Having said that, one might say, well, gee, it's not a lot of money. Well, it is a lot of money. For big healthcare systems, 3%, well, actually, but the risk is a 6% delta between the low and the high end is a big bucket of money. And it's certainly got the hospital's attention. I'm telling you that right now. I mean, I work in that field. And our crew here, our EMS consulting team does a lot of hospital and emergency department work, and we can tell you that in no uncertain terms, this has gotten the hospital's attention and the physicians that provide service. Have we had the same kind of rules and expectations placed on EMS The answer is no. We think we have about a 3-year window before that actually starts to occur. When it does occur, it's likely to have both incentives and disincentives if they follow the hospital and the physician model that's been adopted and endorsed and in place for several years. And they keep adding things every year. So, for example, now, we're looking at hip fractures this year, and with the possible penalty coming up in 2015, whereas in the past it's been congestive heart failure, and thus possibly an opportunity to discuss during our rehearsal here, our mock negotiation session. But so they keep adding things; they're not taking anything away. Why do we think we have 3 years? I think we have 3 years to spend the new money that is going to become available. More insured people. Remind yourself that these are people that had no insurance, okay? Whether it's a nickel or $500, these are people, depending on the range and what type of insurance they bring to the table, they're going to be more insured. But I think for about 3 years, we're not likely to see a lot of risk coming with that money in terms of pushing back on our pricing and what have you. There'll be most of which will be done by and large by providers who are out there proactively seeking deals with entities, healthcare entities, whether it be hospital-specific, payer-specific, or ACOs, Accountable Care Organization-specific, which is a cluster of organizations willing to take risk. But other than that, I don't think there's going to be a lot of pressure, unlike the hospitals and the physicians that are already getting pressure. So that $750 reduction in $1 billion of reduction is very doable, but we have what I think is going to be a bit of a honeymoon period that's going to allow us to really rethink how we do our business, and more importantly, even look at R&D dollars that come in. Because one might say, well, gee, we're going to get all this new money. What are we going to do with that? We're just going to spend it, right? Well, that's certainly one attitude that could be taken, and then just subject yourself to whatever rules come out. But there are a number of other very prestigious organizations, MedStar being on the call today with Matt, who have taken a much different position and said we're going to be proactive, and we are going to engage in proactive strategies and run those tests now as opposed to waiting for those to happen. So once again, we believe this is a tremendous opportunity to take the anecdotal, which there is plenty of anecdotal about health reform. I got to tell you, I can't even get out of my own neighborhood cocktail party without somebody lambashing Obamacare, and I kind of have to remind them it's not Obamacare. The entire Congress approved it, but I'm really high on getting more payment for emergency care. I don't care what label it has or what party side you're on. I don't really care, but it would be a shame to lose this opportunity and just say, well, we'll spend the dollars and let's see what the federal government does to us. And that would be a very prototypical and unfortunate set of circumstances. Or to move towards a more precise, data-driven model that you can test now as opposed to waiting. All right, think cost-effective, think appropriate utilization, think data-driven outcomes. All right, so, some strategies here about where do you go from here. I'm going to leave a lot of that up to Matt in our practice session coming up here. I can tell you that there are entities out there doing this. We just finished a large engagement with the Santa Clara County EMS, which is where San Jose is, which is really an innovation center in itself, irrespective of healthcare in terms of IT in this country, where they are, through a proactive process. We're taken through a journey to look at where the future is, where the low-hanging fruit might be, where are some of the gaps that are likely to occur, and they're now willing, as a result of their elected board of supervisors, have approved a strategic plan now that should move them forward towards an action plan to proactively seek out and work on strategies for the future that will take them beyond just treat them and street them mentality. So the question often is sometimes, is there a meeting? And then if there is a meeting, is there something being talked about? But if all of that is occurring, are you at the table? Do you actually have a seat at the table? And maybe it's your table. Maybe that's the choice you have, is that, nobody else is convening, so should we convene? and I don't know who the we is. There's a lot of different entities represented on this call today, but the point being is a room that's empty with no attendance, a lot of good ideas, a lot of good vision, but no one willing to take the first tippy-toe step is a bad sign for us that would suggest that if we're not careful, we could lose it all because of inertia. Okay, Matt, I've got it off to you. I'm going to hand over control and capabilities to you, and we're off to your portion of the talk.
Thanks, Mike. And I think some of the folks on the phone might have some medication for the detox that you go through for not being in control. But thanks for that great introduction. And for those of us that are on the call and living this every day, I'm going to run through this relatively quickly because I want to make sure that we leave enough time for Bill. He's got some great insight as well. And then we want to leave time for the folks to be able to hear and learn about the opportunities that we have and what we've been doing here. Many of you are on the call because you want to know what this is all about, and we ask you to ask yourselves, why are you here? What do you want your organization to do in this new environment that Mike explained? We are clearly, as he said, in the biggest change probably in most of our lifetimes, and we really have an opportunity that we've never had before. So think about the reasons why you're on this call. Think about why you're learning all the things that you're learning, and decide what your strategy is going to be before you start looking at some of these programs to see if any one of those bullet points truly apply, and then build some of your strategies around what your overall mission is and what you hope to achieve as you develop some mobile healthcare programs in your community. One of the things that we had to do as an organization, and we would encourage anyone to do, is determine, can you really do this? We get phone calls all the time. Mike gets phone calls all the time from organizations that are really thinking about this or wanting to venture down this road, but you need to ask yourself some pretty tough questions. Are you a fragile organization and you're looking to increase your status in the community, or are you able to change pretty easily? Is your medical director committed? Is your hospital community committed? All the things that you see up on the screen, really do an internal needs assessment of yourself to see if your organization really is prepared to do this. There are clearly some critical success factors that we have found in implementing the 5 or 6 programs that we have going on here. First is making sure that you are willing to work in that new role. Will you have a referral source for patients? These programs are great, but if nobody sends patients to you, it's clearly not going to work. Do you have a network of resources to help patients? In many of these programs, you need to have places to send patients that are other than hospitals. If you don't have that ability in your community, you need to really research where you might be able to send some of these folks. Tools to measure your success. This is really important. We'll talk more about this in just a moment, but start to ask your stakeholders and your partners in these organizations, what does success look like to you, to that particular stakeholder? And you'll hear some of that in the mock negotiations that Mike, Bill, and I go through at the end of this webinar. What training might necessarily be involved, not only for your field staff, but for any of your leadership? And do you have a sustainability model? This is so important. One of the key questions that we get asked most often is, how are you funding this? How are you paying for it? And we're going to go through some of that, but you got to have a sustainability model so that these programs can continue on into the future. Grant funding is great, but it doesn't last forever. We love this discussion about the typical project management life cycle. Project initiation, everybody's wildly enthusiastic, and this actually comes from Dan Swayze in Pennsylvania. He does a great job with this. That wild enthusiasm leads to disillusionment, then chaos, then the search for the guilty, the punishment of the innocent, promotion of the non-participants. Then you kind of go back to what was the original definition of the problem that you were trying to solve, and oftentimes it becomes just a dog wagging or chasing its tail. So one of the pieces of advice that we give to folks that come down this road or want to join this group of folks that are trying to take this is, remember that for those of you that are married, you'll appreciate this. For those of you that have been in organizations that may subscribe to this, it's very true that the secret to happiness is to lower your expectations. Start small. It is very important that as you go down this road, take very small bites of the elephant, determine what the opportunities are, determine what some of the challenges are, fix those as you go before you try and take on that large project that you're going to have the biggest bang for your buck. Dan Swayze from Pennsylvania also talks a lot about the potential markets for this. We have found the same thing here. I won't take a lot of time to go through these, but these are the opportunities as you begin to talk with your local stakeholders. These are some of the markets that we here at MedStar and other folks have been able to do and make some significant inroads into to actually have some of these programs adopted and implemented. And Mike, it looks like I may have lost control of the screen. So maybe if you can just sort of help us to take control back over and help us move along in the slides, that would be great. I know you'll be very happy that you're back in control, and that will make everybody happy. Because a happy Mike is a happy life, right? So again, these are the potential markets. We'll move on to the next one. Trying to keep up with everybody here so we don't bore folks. So stakeholder assessment. The first thing that you need to do, and we advise all the folks that contact us, is to, as Mike mentioned, have a seat at the table, really do a needs assessment of your community. Begin to ask the stakeholders what are the needs that these folks have in the community that you might be able to fill. Mike, we can move to the next one. Regulators need to be involved. We often talk about the fact that many of the things that we are doing here and that you can do in your community are allowed within existing regulatory environment. You may need to do some tweaking of some rules or some statutes if necessary, but you'd be surprised how often you can really do a lot of the things that we're doing and that you want to do in your community without having to change a whole lot of rules, because everything that we're doing is essentially expanded role. It is not an expanded scope of care. So in most cases, you're just doing a different role in the community using your existing scope of practice, your existing medical control, and your existing relationships. Mike, we can go to the next one. Those are just some of the folks that we've included in a lot of our needs assessment. You should do the same thing. And then look at what resources are available. Whether they are patient-centered medical homes, community clinics, private clinics, begin to build that network, find what the resources are that are out there for folks that the patients don't know about. When we started our EMS loyalty program 4 years ago, really the big success for that program was finding those resources available for the patients and connecting them with those existing resources. We did not build any infrastructure. We made effective use of the infrastructure. And when you do this analysis, you look at the needs, you look at the resources, and if there's a gap in those needs and resources, then finding out if that's something that you can help with, so that gap now becomes you. You become the bridge to bridge the gap of the resources and the needs in your local community. And Mike, we can move to the next one. There's a difference between involvement and committed. We'll talk about that in a moment. But people that need to be involved in this process are obviously the stakeholders that we listed earlier, but also think about your payers, your clinics, the other community-based organizations. We meet regularly, monthly, with folks from the United Way, the Area Agency on Aging, the others that you see listed there. Media is hugely important. We've involved them very effectively in our community to help promote our message and to help educate our community. And then clearly, always briefing elected and appointed officials, because those folks, more than anybody, do not like surprises. So as often as you can, keep them briefed on what you're doing, give them options to have input into how this is working. And Mike, we can go to the next one. These are other folks that need to be involved. Transportation is probably one of the biggest issues that we face with our patients that we serve under these programs. And the reason that transportation becomes such an issue is even if you have the referral source, you have the network, you got to figure out a way to get them to those. We have a partnership with our public transportation authority where we get free bus passes for patients. We have a contract with a taxi cab service that gives us a discounted rate to get people back and forth. And there's actually some local charitable transportation organizations that we can refer patients to get them back and forth to their appointments. Mike, next, please. Now, here's the difference between involved and committed. If you think about your breakfast this morning, you may have had bacon and eggs. The chicken at your breakfast table was involved in your breakfast. The pig was committed to your breakfast. So these are the folks that we have found need to be fully committed to your programs, to your path down mobile health care. Medical directors, physicians, the hospitals, all the folks that you see listed there really need to have skin in the game and be fully committed to the project. Next slide. This is an example of one of our local medical centers that put together a resource guide doing that gap analysis. These are all the resources. They hand these out to patients. We have similar guides that we use in our local community, but you might want to think about just having that guide that you can hand out to folks as you're referring them to the resources in the community. Next slide, Mike. So what is going to be your business model for this service? Some folks, it's going to be a free for service. We started down that process. We had to generate some data, generate some proof that these programs work. Are you going to do fee for service? What is the marketing mix going to be? And Mike, we'll just kind of skip through the next 3 or 4 slides, trying to be cognizant of the time here. Excellent. And again, folks will have these, and that you've been emailed these slides, and certainly Mike is available, and I and others on the call to help you with this. The one thing we do want to highlight here, and it showed up there first, is the jurisdictional boundaries. You will find, as we have, that your medical community, your healthcare community, and your payer community are generally not limited to your geographic coverage area. So as you begin to build these types of programs, be very cognizant of the fact that quickly you're going to be asked to do services that are outside of your city border, outside of your county border, outside of your EOA. The medical trade area is much different than our jurisdictional boundaries, and the payers and the providers, quite frankly, don't care about jurisdictional boundaries. They care about where their patients are going home to and where you can have an impact on them. So consider building a network to help do that. Mike, next slide, please. Price, this is a lesson that we learned early on. When you build your program, be aware of the fact that your cost of delivering service does not have any relation to what people are willing to pay for it. We've seen that on the negative side in the ambulance industry for the last several years, thanks to MedPAC and CMS and others. Certainly some large payers have treated us as a commodity, if you will. But in this particular case, we have found that the value that we bring to this equation are much different than our cost of providing service. So you'll see that more in just a moment, but just wanted to make that point to folks. And here's an example, Mike, on the next slide. Recently, CMS has published a bunch of data on hospital charges and what they are paid for those particular charges. We'll just go to that slide, Mike, where it shows the CMS. We'll wait here for a second. We'll go back to that in just a moment. Sorry about that, folks. We talked about the measurement of the program, making sure it looks successful to the eye of the stakeholder. When you develop these programs, ask the payer, ask the hospital, ask your medical director, when we do these things or when we are operating these programs, how will we know when we've been successful? That has a very positive impact on making sure that you're tracking the right information, reporting the right information, but also it prevents the other stakeholders from changing the rules of the game as you go. So that has helped us quite a bit in defining what those success measures are and then reporting them. And that way you know if you're not successful, how can you change the program to make it successful? We've had an experience with our congestive heart failure program exactly in that way. So make sure that you help define what those rules of success are, what success looks like as you develop these programs. Next slide, Mike. These are some of the data reporting. And again, we generate an amazing amount of statistics, but you want to look at what are the clinical, economic, and other factors that the stakeholders believe are going to be important. We do things like resource utilization. You'll see posted on our website, and we send out to all of our stakeholders what the utilization has been, what the economic impact of that utilization change has been. But we also ask a lot of patient satisfaction questions and report patient satisfaction data, because many of the stakeholders now specifically care a lot about patient satisfaction. We also track the patient's perception of their health status so that we can show the result of a patient being enrolled in one of our programs that they have actually improved their own perception of their health status and ability to maintain their health care. Mike, next slide, please. When you're going to start pitching your community paramedic services, your mobile healthcare services, bring all these people with you. Oftentimes, docs want to talk to docs. Hospital administrators want to talk to hospital administrators. We host site visits here regularly at MedStar where we have folks come from all over the country, and they spend a day or 2 days here. But we find out who's coming so that in some cases we partner and bring hospital administrators to meet with hospital administrators, medical directors to meet with medical directors, because they speak the same speak. Their DNA is wired the same. So think about all the folks that you need to have involved when you begin to pitch these services to your potential customers. Mike, next slide, please. This is an example, again, Dan Swayze has done a great job. In addition to MedStar, they've been operating a community paramedic program for several years through the health plan up in western Pennsylvania. And we'll go through a couple. Mike, just give me about 10 seconds on each slide, and I'll summarize some of the programs that they've been doing up in the western side of Pennsylvania. Oh, maybe Mike was stuck to it. There we go. So they've done a worksite wellness program where they actually do vaccinations and biometric screenings on their own health system employees. The health system found that that was actually much less expensive having their mobile healthcare paramedics do it than actually sending these folks to one of their own internal clinics. And Mike, you can just kind of keep rolling through these, and I'll highlight them as we go. They have an asthma program. That's something that we're starting here locally as well, where they find patients that are at risk for asthma attacks and mitigate those before they actually end up in the emergency department using peak flow meters and PCP follow-up, very important, helping those patients identify when they might be getting close to a asthma attack. Safe Landings, this is a program that we've been doing as well, but again, it meets with those patients at home, goes through their home assessment. Are they in a safe environment? Are there throw rugs, fall risks? Do they have all the medications that they need? They actually do a minor medication reconciliation where they'll actually look at all of the medications to make sure they're not duplicated. And there's often talk about this one patient that's become a sentinel patient that had 3 prescriptions of Coumadin and was taking all 3 of them because he was following the physician's instructions. They just happened to come from 3 different physicians who didn't know that that patient was already on Coumadin. So you can find those little things and make those changes to help potentially avoid a medical catastrophe in those patients. Another program, or this is still part of that Safe Landings program, again, you can see the savings there. Now, a word about costs, and I think we may go into that in just a minute, but the cost discussion is very important for you all on the call to understand there's a huge difference in how you're measuring costs. You have charges, which have no correlation to payments. You have payments, which hopefully have some bearing on the actual cost of providing the service. So we refer to all of our analysis as expenditure savings. What are checks that are not having to be written or smaller checks that are being written as a result of the programs that we're administering and helping our community with? So that sort of becomes the bar by which a lot of these are measured. And I think, Mike, if we go to the next slide or 2, we'll go to the Medicare example. Yeah, we'll skip over because we'll talk about our CHF program as well. They've been very similar. So let's talk about our EMS loyalty program. We'll get to the charge discussion here in just a moment. So when we started our program, this was an EMS loyalty program or frequent flyer program. Very successful. We've reduced the 911 use in those patients and the ER visits by 85% over the course of the year that they've been in the program, about a 50% reduction just in the first 30 to 60 days. And again, that's connecting patients directly to other resources that are available in their community. If folks don't do well in those programs, we do move them to a system abuser status, and you can see how we handle those patients differently. But again, helping those patients get their health care in a more appropriate setting. And Mike, we can move on. Here we are, finally, cost. So you have charges, expenditures, and opportunity cost. So we don't use charges in a lot of our reports because the billed charges have really no correlation in anything. We do look at those expenditures as we talked about earlier, but also there's been a lot of discussion, well, it would reduce bad debt. The issue with the bad debt discussion is it's an accounting issue that, yes, you can reduce bad debt by having billed charges that are not collected reduced, but by definition, that also means you're reducing your billed charges. So taking the bad debt out of the equation also means that you're reducing your billed revenue. So we don't talk about bad debt anymore either. That is something that we've learned as we've gone through this process. So try not to use bad debt as a discussion or uncompensated care as a discussion in some cases as you're moving down this particular path. And here's an example. This is an example that we did here for some folks that were visiting from New York, and we were visiting with folks in New York. And you can see there that Mary Washington, the charge for a pulmonary edema admission is $51,000, but at Scott and White Hospital here in Texas, that charge is $23,000, and at Maimonides in New York, it's $76,000, $77,000. But you'll notice the payments that are paid by Medicare aren't drastically different in those scenarios. Same with diabetes. So you just have to be really careful and very realistic about how you depict your cost savings as you are doing the evaluation of these programs. Mike? One of the programs that we've been doing with a very large success, and this kind of starts the funding discussion, is this 911 nurse triage program using the low-code software by Priority Solutions. This is a very extensive, protocol-driven, algorithm-based 911 nurse triage program where we take the low acuity, those alpha and the omega calls from the EMD side, pass them on to Susan Pelton, who you see there on the slide, and she works with those patients to get them sent to the right place. The toothache patient goes to the dentist, the hiccup patient goes to the clinic, the minor ankle injury goes to the orthopedic physician. Again, getting those patients to the right facility in the right time and in the right setting to help make their outcome better and, quite frankly, meet all of the IHI triple aims. You can see some of the results there. This is a program that is currently being funded by our 4 hospitals in our community. They are paying the cost of the nurse. We employ her, but they are equally sharing in her cost. And another hospital system has recently partnered with us where we're going to actually add another nurse to this process to increase our coverage, and that hospital is funding the entire cost of that nurse as well. Mike, we can go to the next one. These are the things that you need to look at when you're going to do this, and for many of you on the call, I noticed in the attendance list that Mike sent me have a very significant financial acumen, so we won't spend a lot of time on here, but just make sure that you're analyzing all of the costs of providing the service. We've been doing it for 4 years. It costs us $500,000 a year to provide this service. We are now finally beginning to see that return on the investment where we're actually getting some pretty decent revenue from these projects. Our belief is that as we've seen the growth in our mobile healthcare programs grow much more dramatically than the growth in our traditional 911 service, that this will become a significant portion of our revenue stream starting next fiscal year. We actually have a pretty good revenue stream this fiscal year, but it'll increase even more next year. Mike? We can move on from this slide as well. Seed money. So when you want to get these programs started, there are a couple of ways to do it. Grants always work well. What we have found in working with some of the folks that are working with us is that hospital foundations generally are agreeable to look at programs like this, and there are other local resources to meet some of those models. You do need to find that sustainable funding model, whether it's a fee for referral, fee for contact. We'll see some of those in the strategies that we do at the end of the webinar with the negotiation strategies, or finding other revenue sources using these resources. So we use our mobile health care paramedics to provide critical care transport and some other things that we hadn't done before, so that's been some new revenue that has come into the program as well. Mike? Shared savings is an interesting concept, and you'll hear more about that as we do the final session. But quite frankly, what that means is that you have a payer who saves money as a result of you intervening in the patient's navigation, and you ask them to share with you a percentage of that savings. It's one that we are now transitioning a couple of our paid agreements to a shared savings model. It's a very low risk to the payer, because if you don't save them any money, then you don't get paid. Of course, that means it's a higher risk to you, but that has been a very agreeable discussion that we've had with several of our payers, and we're actually working on some language for that contracting now. Next slide, Mike. And we can go to the next one. Again, just trying to be cognizant of time here. Next one. Communication, very important. Make sure that everybody who has a stake in your process is communicated with regularly. We host monthly meetings with our stakeholders. We brief our board regularly. The medical control authority is briefed regularly by our medical director. Everybody who has a stake in this process, including elected officials, gets regular updates on the programs that we're doing. And quite frankly, that serves as a marketing tool, because many of those folks talk to other people and then they call us and say, hey, we've got this other issue that maybe you can help us with. So just be sure you're communicating with everybody as much as possible. Mike, you can keep going, sir. There's been a lot of discussion about, is this mobile health care, is this community paramedicine? Our main message here to you is that it doesn't matter what you call it. Pick a term, stick with it, make that your mantra. We chose to use mobile integrated healthcare practice for a number of reasons that you can read about in the EMS World article that just came out on this project, but we think mobile integrated healthcare is a much larger term that encompasses not only community paramedicine, but nurse triage and all the other things that we're doing in our community. So you might want to just consider what your term is going to be, whatever works best for you. We put up there the Mesa, Arizona example. Mesa has partnered with Mesa Fire partnered with their hospital system and are actually providing a nurse practitioner with a paramedic in a fly car. So this isn't just paramedicine. It could be EMTs, nurse practitioners, PAs, MDs, whoever. So it might be more than community paramedicine. Mike? I think we're almost done here. To Mike's point about the fact that we've got a narrow window of opportunity here, we talk about it all the time. The hospitals are figuring this out. Other care providers are figuring this out. So if we do what EMS typically does and wait to see what happens, wait to see what happens, wait to see what happens, we're going to be like the unicorns. And why we have no unicorns anymore is because they got left behind because they missed the deadline for getting on the ark. So let's not do that. We don't want to do that again in our industry. Mike, I think we're almost done, and we can transition over to Bill. Yes, no?
Thank you very much, Matt. Bill, this is yours, and I'll take control if that will work for you.
Sure, that'll work great, and we'll cruise through these so we have some time for everybody to have some fun with the interactive part. So in our experience, we've had a great opportunity to talk with a number of different industry experts and really determine some trends and best practices. And typically these involve some level of reducing improper utilization or really getting the right resource to the right patient, which is kind of a mantra of the MedStar system we've been hearing about. Basically, we've got 4 different types of best practices that we are looking at. Mike, you want to advance? And you'll see here a number of different communities that are doing that: Fort Worth, Mesa, and all the way down to Florida, upwards into Canada, a number of different programs. First, we're going to talk about the 911 dispatch triage and awareness. Next page. And really what we're looking at here is how do we potentially take somebody before they enter the transport side and divert them to a more appropriate resource. And you can see examples here of 4 systems that are currently doing it and some savings that they're showing for that. Toronto has a program through the Ontario Public Health Division, which is, as you can see, a dramatic driver of cost savings by not sending everything through to a traditional transport. And really what makes these effective is not so much the nurse triage or any type of triage, because it's also done with EMTs, but also the ability to have an alternative for the patient. So these systems work well when they're able to refer to an urgent care or a primary care opportunity. And systems that don't have those don't refer enough to really make an impact. And that's the case with Richmond, Virginia. For those of you who are familiar with them, they were an early adopter of this, but weren't able to get the community support to really create an effective system, didn't see the cost savings, and ultimately ended up moving away from the program. The 911 awareness campaigns, and this is just a great example. We've been our own worst enemy. We've marketed 911 since we all turned 4. And just if you have a problem, you call 911, and then we'll figure it out from there. Well, guess what? We did a great job, and it's working fantastic. Everybody calls 911. And a lot of systems are now finding themselves going through an educational process. One of my favorites is London Ambulance Service has the Use Them, Don't Abuse Them public education campaign. Lake County, Florida has a When to Call 911 program. That's now being replicated in other states, and it covers not only when to call, but also what's going to happen when you do make that phone call. Next slide. So let's say that you do need to actually transport somebody. Well, does it always have to be by ambulance? Are there other methods and opportunities that we can use? And one of the ones we hear quite often about is mental health. When somebody gets put on a 72-hour hold, we call a 5150. How do we make sure that patient really gets to the appropriate place for them? And does everyone need to be put on a 5150 hold, or is there another opportunity? In San Mateo County, Santa Barbara is another example of both creative programs. San Mateo's is still doing well. Both had funding issues, but the San Mateo program has survived. And by offering some alternatives to a paramedic that's able, a mental health paramedic that can come out and work with a particular individual and potentially not have them go onto a 72-hour hold, but can then get them to, again, what we're talking about before, other options than an emergency department. Maybe that's a primary care or an urgent visit by some type of a psychiatrist or psychologist. In San Francisco, we have a benefit of a fantastic sobering center. We also see these programs going on in other places such as San Diego, Las Vegas, Spokane, Washington, and they have done an excellent job of not only pushing patients out of ambulance transports, but ultimately where does that ambulance take them? Well, the emergency department. Well, then they end up sitting in the emergency department, sobering up until they can be discharged. And that's just a huge resource drain on all parties, not just EMS. So what we're seeing here is an ability to take these patients, stop that, break that flow, and get them to the most appropriate care. San Francisco is unique in the sense that they will take what we'll call unhealthy patients as well. So these people, there's a nurse, they get screened, and they will actually medically monitor them and not just say, okay, well, this person's got some type of condition, we're not comfortable, we're going to send them to the emergency department. And that really allows San Francisco's sobering center to accept a quite higher number of admissions. You can see 2011 they had over 5,000 referrals. They in Spokane actually go out and pick up patients as well. So it's not just referrals from EMS or PD. You can see we've got two communities that are doing taxi cab vouchers, basically going through a triage system at dispatch level, determining these patients do not need any type of medical care and are being sent by some type of voucher program. This is obviously a very protocol-driven and very conservative program, or else you end up with significant risk of some type of medical incident due to that screening not happening properly. Next. So looking at high system user diversion, or as Matt likes to call it, his EMS loyalty program, Fort Worth probably has one of the best programs around as far as showing just what the impact can do, positive impact. So 21 people were calling 911 enough times that they represent 1% of all calls, more than 1%. I mean, that is just crazy. Well, his program was able to come in and cut that by 86% within a year. And you can see some cost savings numbers on here. San Diego similarly noticed that over 10% of their patients came from 933 people. And so they looked at that and then looked at a case management approach. How can we provide these people the services they need ahead of time before it becomes an acute incident and they call 911? It's called their RAP, their Resource Access Program. And also they have a SIP program, which is for serial inebriates, which does another excellent job of coming in from a case management point of view and steering people away. Next slide, please. I'm going to skip over this slide just because we've talked about Fort Worth fairly well. There is a slight mention in there about Alameda County that is doing portals where they're partnering up clinics with their fire departments, and these are actual new brick-and-mortar structures where there's a new fire station combined with a clinic to offer services. And that's something that we're going to see launched later this fall, and we're quite interested to see how that comes to play in the environment. So CMS is not standing by and watching what's going to happen. They're actually putting money out there. They've funded up to $1 billion in different innovation grants, and 3 of those that we've seen specific to EMS are in Nevada, Washington, and Colorado. Probably the one most focused in EMS is the REMSA program. That's in Reno, Nevada, and that's focused on another community health paramedicine model, trying to attack unnecessary ambulance responses, ED visits, hospital admissions and readmissions, and they're looking at a savings over the 3-year program of about $10 million is what they're talking about. They're about a year into that program, and we are looking forward to seeing the first report out of how that implementation is going. we're seeing similar programs being funded. There's actually a second round of innovation awards happening shortly. And next slide, please. The last innovation we're going to talk about here is a program. Oh, is there one more back? Let's see here. Should be one more in between. The Beacon Community Program in San Diego. And go. There we go. This is a really interesting program where the Health and Human Services has awarded a $15 million grant to our friends in San Diego to create a true real-time data system that will connect pre-hospital and hospitals together into one health information exchange. And this is going to enable the paramedic in the field to access the patient's medical records in real time while treating the patient, know their hospital, know where they should go, and then take them to their definitive care location. It enables a hospital that receives a patient that they have not seen before to look up that patient's records at the other hospital and find out, is this somebody that should be going over there, what's their history, without having to perform serial tests again and again to get a baseline to know where this patient's medical care needs to go. It's a quite innovative model. We're seeing this done. They're currently in the stages of getting everybody onto that network, and will definitely be something that we're going to want to watch and see where they take it. The bottom line is we're going to see better pre-hospital care because the paramedics are better informed. We're going to find better quality improvement because all this data is now being housed in a central database. And hopefully we're going to see reduced hospital utilization and decreased ED times. So with that, I'm going to end my presentation and turn it over to our little bargaining negotiation session.
Thanks a lot, Bill. Juliana, while we're getting set up here, I know we have about 10 minutes left. I believe there's at least one question in our queue. Do you have any others that we should be aware of?
Oh, yes, we have many questions.
Imagine that.
Yeah. One is, we hear a lot about accountable care organizations. What are these exactly? They sound like clearinghouses for medical care.
Mike,
Matt, you want to take that?
That was too funny. Juliana, can you just repeat the question once more for me?
Sure, absolutely. We hear a lot about accountable care organizations, ACOs. What are these exactly? They sound like clearinghouses for medical care.
Sure. What we have found, structurally, there are partnerships between different providers, payers, that can take many different forms. But essentially, they are in an arrangement that is geared specifically to benefit from improved outcomes and reduced costs. So if Mike were an insurance company, I was a physician group, and Bill were a hospital, we would all get together and say, we're going to manage these 20, 30, 40,000 patients, and we're going to go at some risk. If we can improve their outcomes, reduce their cost of care, and keep their patient satisfaction high, quite frankly, then we get to share, in some cases, the savings from that program, or, well, there may be a whole bunch of configurations, but in a nutshell, that's essentially what it is. Divergent providers, payers that get together to manage populations of patients to improve outcomes, reduce costs, and share in the benefit.
Great. Mike, do you want another question, or would you like to?
I think, if you don't mind, I'll just add a little bit to what Matt said, and then we'll move on to the script here. By the way, any questions that's not answered online will be answered offline via direct email back to everybody, so you'll all see the same questions and answers. But I think the other important point is about north of 220 of these ACOs occurring right now, some of which are considered legacy. They started early on, and they were used as test vehicles. And so what's contained within that bucket of risk-taking and risk-sharing organizations is variable amongst a variety. Some are just physician-driven groups. Some are hospital physician. Some have a heavy focus on home health care. And so just because you've seen one name in one organization doesn't mean you've seen them all. Also, there's been some variability. Some of the ones, a small number of those that participated early on as ACOs in the pilot projects have decided not to renew. And so it's not clear that this is the bee's knees to how risk-taking will occur in the future. But I can tell you both to Matt's, Bill's, and my immediate concern is the fact that no ACO that we're aware of has had any EMS provider or any EMS leadership group involved in their thinking process, strategic planning, or on the scope of services, and that's not a good sign. We're essentially being left out, and I would guess most of that is related to ignorance and not knowing, some of the facts that we presented today about how less than 1% of the costs may be driving for some patients up to 60% of their overall risk of costs. So with that in mind, what I thought I'd do, and Matt, you and I, and Bill's going to be kind of our devil's advocate here, is just run through some of these questions. We don't have time to do them all, and just to see how this script will go. All of you should be seeing the script up on your screen now, and I think the original goal was to have some sort of an event that would be look as normal as possible about a typical, if there is such a thing, engagement between a provider of healthcare services, in this case an EMS provider, to a buyer of services. That could be anybody. That could be a hospital, a healthcare delivery system. It could be an HCO. It could be a payer, a Blue Cross Health Net type entity. Or it could be a completely integrated payer, such as we have in the West Coast, say an organization like Kaiser. And in fact, some of our earliest deals, risk sharing and EMS, look like that are gaining traction in California are with Kaiser. So with that in mind, I think I'll go into character here, Bill and Matt. And Matt, I understand you're here today, and I'm going to be a buyer, and characterize what you want that's most convenient to you, Matt. But so what is your purpose here today?
Well, Mike, we know that you are going through, just like everybody else, some significant changes in how your hospital receives funding. The era of healthcare finance reform has really changed the landscape, and we just wanted to educate you on some programs that we believe we could partner with you to help improve the patient outcome, reduce your cost, and help you remain financially whole through these turbulent times.
Wow, I mean, it sounds like something we'd be very interested in. Can you be more specific? What kind of services are you talking about, and how might we benefit?
Well, we've learned a lot over the last year or so from these Yahoo organizations in Fort Worth, Texas, and Pennsylvania and California. They're doing a couple of programs that we think you might benefit from. We've done some research on your system, and we find that you're part of the Plus ACO, and you're at risk for some of your patients. And what we found on the CMS website is that for an observational admission, you're actually spending a lot of money to keep these patients overnight in a hospital for observation. There may be an opportunity for us to work with you on maybe getting some of those patients sent home, and we can follow up with them at home to see if there's a more effective way to have us help manage their care that helps eliminate that spend for you when those patients stay overnight in observation status.
So these are patients that we might put in the house from, say, for example, from an emergency department visit, and we're not ready to send them home yet. We're not quite sure what unit they'd go to or whether they need a full unit, but we would put them under, a 48-hour or less observation status, which is that the type of patient you're talking about?
That could be exactly right, Mike, and we know because we've been bringing you these patients for years, and those patients get held overnight oftentimes not necessarily for medical reasons, although sometimes they may have an appointment tomorrow with a neurologist or with somebody after a fall at home, and the ER doc just, I'm not sure what's going on at home, so maybe he doesn't want to send that patient home, so you hold them overnight until they're going to have their follow-up appointment tomorrow with their PCP, with their neurologist, and quite frankly, that costs you a lot of money. Because, as you know, you're in that ACO, so if you cannot have that patient occupying that bed overnight, not have the ACO have the expense of keeping that patient there, we can get them home, do a home assessment, what's going on in the house, do they have a little Pomeranian that they're tripping over, do they have throw rugs, do they have whatever that might be causing these falls, or is there something else going on? Provide that information, to the primary care physician, make sure the patient's safe overnight, and by the way, make sure they actually make their follow-up appointment tomorrow, which we know is a real concern of yours because a lot of patients don't actually make it to their follow-up appointment.
Well, you know, Matt, I don't know whether you know this or not, but this couldn't be any better time. We are really getting pushed back on by CMS for overutilizing our observation status, and it turns out when we look at ourselves and compare ourselves on Medicare, CMS's Hospital Compare website, we're finding that our utilization of observation status is 2 times above the standard deviation of any hospital in the area. So we know we have to do something about this, but it just never occurred to us that we would go to our ambulance company, because isn't that what you really are, as an ambulance company?
Well, historically, that's what we've done. But we know, much like you've had to go through some changes, that we have to transform as well to better meet your needs and be a better partner for you in the healthcare system.
Wonderful. And you know, not to short-circuit our conversation, but I assume that we could get to a point, if we aren't going to be able to get here today at our meeting today, to some numbers and what those would look like, and some execution strategies and what those would look like?
Absolutely right. And I know that Bill is here sitting next to you, and he's the CFO of the organization, and quite frankly, a very shrewd negotiator, so I'm sure that he's going to weigh in here in a moment. But what we have been talking about with some of our stakeholders is we want to operate in the environment that you are financially. So if we are successful in receiving a patient from your emergency room physician that we're able to keep out of the overnight observation, you don't have that expense, we get them safely navigated to their appointment the next day, and you have a savings. You tell us what that number is, what you saved, and we just ask that maybe we work out an arrangement where you share some of that savings with us. If we're not successful in keeping that patient out of the emergency room for you until they get to their appointment the next day, then don't pay us. So we're sharing in the risk of that particular arrangement. Bill, what do you think about that as the numbers pencil guy?
So, Matt, are you telling me I don't have to write you a check if you don't cost me any money?
Sounds kind of familiar. It sounds kind of familiar with how you're being paid, but that's exactly right. So if we don't perform for you, if the patient's outcome isn't better because of our intervention, then you don't have to pay us.
That's probably something that I can't argue with too much. What about, you know, we're having this problem with these readmissions. We're sending these people home, and then they're coming back within the first month. And, you know, I see those, boy, those are just a big red flag on our monthly statements, and I just hate that.
And as you know, it's going to get worse because the penalty for that goes up to 2% next year under the new healthcare financing reform.
Yeah. Don't remind me.
We would love to work with you on that program as well because we're mobile. We're out in the community. We see these patients. We can stop by and see them. We can do all sorts of things to help them prevent having to come back to the hospital, go to your clinic, go to their PCP, a number of ways, and we can work out some financial arrangements for that as well. But we think we can be a much better partner for you than we have been in the past just by bringing you patients you call, we haul.
Well, I would say right now that this all seems like a home run, and so those of you who are looking at the script that you don't have as part of your handout, we will include that because it does call out some bullets, some typical questions, maybe what a mini business plan would look like if you're thinking about an engagement or relationship, and then some other strategies. Well, folks, I do know that we wanted to cover much more, and we always pride ourselves on promising a lot and doing as much as we can down that rein. Juliana, do you want to take us home?
Yes, thank you all very much for attending today's webinar. As Mike mentioned, we'll be answering all the questions and answers. There are several questions, and we'll be answering those, typing them up, and sending them out with an email to follow. And also, you'll be receiving an email from me with a brief survey for you to do an evaluation of this webinar today, which we would really appreciate your feedback. Thank you all very much for your time today, and we look forward to seeing you again on another The Aberris Group webinar. Thank you.